We'll go ahead and get started. Hello, everyone, and welcome to the Learning Lab event. Insights into 1115 waiver updates, community hub models, and Washington Healthcare's role towards better care. My name is Emily Noodleman, and I am the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the BRIE Collaborative Program and the implementation of the reports into practice, and also support the Foundation's health equity work. We're all very excited to have each of you join us today, along with our speakers, as we engage together in an event and explore our healthcare ecosystems, ways that they can support one another's work to promote equitable health for Washingtonians. As we begin, we'd like to review a couple housekeeping items. Firstly, if you could ensure your first name, last name, and credentials appear in your username on Zoom, that'd be greatly appreciated. We utilize this information for our attendance records. This event is being recorded and will be accessible on our website in a few days. We intend to send out the recording and a PDF of the slides to those who signed up to attend the event. For the agenda for today's event is first we'll provide a short introduction to the BRIE Collaborative and Foundation for Healthcare Quality. We'll then have the opportunity to hear from our speakers on the 1115 waiver updates and community hub model designs, followed by a panelist discussion where we can pose questions you may have for our speakers. You may place your questions into the chat box at the bottom of your screen, and we'll work on asking those questions during that time. After the Q&A with our speakers, we will then transition to a small breakout room activity to engage in a facilitated discussion where we connect further and learn with our peers. Finally, we'll come back as a group and just wrap up and close the event. As we begin, we just want to say that there's no disclosures we have. No one in control of content has indicated a relevant financial relationship with an ACCME-defined ineligible company, also known as a commercial interest. All clinical content presented will be evidence-based and unbiased. The Learning Lab event has been approved by WISMA for individuals to attain CME credits. The CME credits are available to claim for individuals who are attending the live event only. Unfortunately, we're unable to provide CME credits for individuals who watch the recording. To receive the CME credits, please complete the post-webinar survey, which will be linked at the end of this event. We will detail how to claim that CME as the end of the event concludes, and we'll also send out an email. The learning objectives for today's webinar are to identify how a BRIE or Foundation Healthcare Quality Guideline can be implemented into practice, recognize how social drivers of health can impact a person's overall health status, plan or modify strategies to center health equity into quality improvement initiatives, engage with peers working throughout the healthcare ecosystem who are in attendance today. So as we wanted just to be able to provide you with a little introduction to the Foundation for Healthcare Quality and BRIE Collaborative. The Foundation for Healthcare Quality is a nonprofit organization that is home to about 8 programs, including the BRIE Collaborative. The BRIE was developed in 2011 by the Washington State legislation so that public and private healthcare stakeholders would have the opportunity to identify specific ways to improve healthcare quality, outcomes, and affordability and health equity in Washington State. These stakeholders are appointed by the governor as collaborative members and represent public healthcare purchasers, private healthcare purchasers, health plans, physicians, and other healthcare providers, hospitals, and quality improvement organizations. Each year, our members identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. Once a topic is identified and chosen as a focus for the next year, the BRIE Collaborative forms a work group of subject matter experts to develop the report that provides information and guidelines for actions different audiences can take within the healthcare ecosystem to improve the care for that topic. In our reports, we've begun to introduce new guidelines recommending the healthcare system and health plans implement screenings for social determinants of health. For example, our perinatal and behavioral health report advises healthcare providers to screen pregnant or postpartum individuals for SDOH needs using validated tools. While screening is a vital first step in addressing health-related social needs, it's essential to explore additional ways to support individuals when they express these needs. In 2023, the Foundation for Healthcare Quality released reports focusing on health equity, including one on social needs screening and another on social need intervention. In those reports, we recommended several strategies for healthcare systems, including initiate partnerships with community-based organizations that involve those with lived experiences, and developing clinic-community relationships to create healthier environments. While we also had recommendations for community hubs, where they were asked to replicate CBO networks as hubs to curate and manage networks of community service providers with hubs at local, state, and multi-state levels. Implementing these recommendations can be complex. For example, changes to contracting models, like the 1115 waiver, affect the opportunities for supporting individuals in determining where we need to focus our efforts. In today's webinar, our speakers will review the latest updates to 1115 waiver, and we'll also hear from 2 community hub models from their implementation strategies and discuss how our healthcare ecosystem can work together with them to support our shared clients. Our speakers for today are Sagung and Colina from the Healthcare Authority, along with Matt Christie. And we have 2 community hubs located in the state. We have a speaker, Tavish Donahue from Community Hub Director at Healthier Here, and Michelle Ahmed, the Director of Health Connect Hub at Swatch. First, I'll pass it off to the Healthcare Authority.
Hi, good morning, everyone. My name is Sagung Colina, Senior Health Policy Analyst. I'll pass it along to Matt Christie for his introduction.
Thanks, Sagung. My name is Matt Christie, and I supervise the Foundational Community Supports Program here at the Healthcare Authority.
Next slide, please. Today, we'd like to go ahead and kind of share with you the overview of the Medicaid Transformation Project 2.0. Next slide, please. In June 2023, the Centers for Medicare and Medicaid Services, CMS, approved a renewal of our state's Section 1115 Medicaid Demonstration Waiver. We call this waiver the Medicaid Transformation Project, MTP, and the MTP renewal as MTP 2.0. In the MTP 2.0 application, we proposed multiple changes to our existing MTP programs and proposed new ones. CMS approved most of these changes. Next slide, please. Thank you. The following infographic is an overview of the continuing programs and new programs of MTP 2.0. The white hexagons represent the 7 categories of MTP 2.0. The colored lines of the hexagons are programs that are continuing from MTP 1.0 into 2.0. For example, in purple on the top left, this is the category for behavioral health. And we have 2 programs that are continuing from MTP 1.0, and that's the Substance Use Disorder IMD, the Institution for Mental Diseases, along with the Mental Health IMD. And then you can see that the white border lines of the hexagons are new programs. Again, using the purple as an example, we can see that contingency management for SUD treatment is a new program in MTP 2.0. In the middle, we actually can see the ones that are colored gold as that represents the health-related social needs program category. And within that are 3 new programs, the development of the 9 community hubs, along with the 1 statewide native hub, and the menu list of health-related social needs, HRSN services. So this is just an overview infographic of the current and new programs for MTP 2.0. Next slide, please. Highlighting some of the new programs we have for MTP 2.0, we have the Justice-Involved Pre-Release Services, Medicaid funds for limited health services in prisons, jails, and youth correctional facilities, rental subsidies for up to 6 months, and the HRSN services such as nutrition, housing, medical respite, and the development of the 9 community hubs and 1 statewide native hub. Next slide, please. A closer look of HRSN services, Community Hub, and Native Hub. Next slide. Thank you. HCA received authority for a menu of HRSN services. There are 2 approaches that the state is exploring. The first pathway is through a combination of in lieu of services, ILOS, and 1115 waiver authorities to ensure availability of HRSN services across both managed care and fee-for-service. A second pathway is through an ILOS managed by MCOs and in partnership with ACHs. Populations to include for fee-for-service are American Indian Alaskan Native, AIAN, those who opt out of managed care, along with dual eligibles. Next slide. This is a menu list of HRSN services. There are 10 that are approved by CMS for Washington's MTP 2.0 waiver. The first we see is the category of nutrition supports. It's actually one service. Nutrition support is one HRSN service, but within nutrition supports, there are subcategories: nutrition counseling and education, medically tailored meals, meals or pantry stocking, fruit and vegetable prescriptions, short-term grocery provision. Along the next category, we have the housing and home environment, and that's recuperative care and short-term post-hospitalization housing, known as medical respite. We have housing transition navigation services that will be delivered primarily through Foundational Community Supports, FCS. We have rent temporary housing for up to 6 months, again, delivered primarily through FCS. We have community transition services, personal care and homemaker services, and transportation for non-emergency, non-medical services. And this is being considered to be paid outside of the HRSN framework. We have stabilization centers, rehabilitation programs, caregiver respite services, medically necessary environmental accessibility remediation adaptations. And then the last category is the case management, outreach, and education. And that is what we are calling Community Hub and Native Hub. Next slide, please. One of the deliverables for CMS is a HRSN service protocol document. Per CMS requirements, this protocol must include, for example, a list of HRSN services that were approved, service descriptions, the criteria for member eligibility, requirements for a documented process, provider qualifications, for example. And these are requirements and guidelines per CMS that the state will have to provide. So the HRSN service protocol was submitted to CMS and is currently under review by CMS. This specific slide that I'm sharing today is an example of information in the HRSN service protocol pertaining to member eligibility criteria, for example. Using the waiver special terms and condition, STCs, that is Washington's contract with CMS for MTP 2.0, and CMS's HRSN framework released last year, we developed the member eligibility criteria. So individuals that will need to meet to receive HRSN services, be one of the eligible in the covered population, have at least one of the clinical risk factors, have one of the social risk factors, and have that HRSN service be determined medically appropriate. We would like to note that the clinical and social risk criteria is being developed to align with an ILOS guidance that's currently under development. And also one thing to note is that for other states that are being approved for HRSN services, it's very similar to what other states are doing at this time for their waivers. I'll pass this now along to Matt Christie, and also next slide, please.
Thanks, Sagung. And so again, just to reiterate, I'm Matt Christie, and I supervise the third initiative under the original MTP 1.0, known as Foundational Community Supports. And we'll be focusing on this portion of the slide on the work that we're doing around housing and the health-related social needs services framework. And so the two benefits that we're currently designing and implementing or preparing to implement in Washington are housing transition navigation services. And those services include things like first and last month's rent, security deposits and application fees, basic home goods and utility assistance, and the types of things that we've been doing in Washington with some limited state dollars that we've implemented over the last 2 years. For those of you who might have heard of the Transition Assistance Program, it's really identifying the financial barriers to establishing a household for an individual who might be exiting an institutional setting or exiting homelessness. So things that your traditional rental assistance programs wouldn't necessarily cover outside of the scope of your ongoing rent. And the second benefit, as Sagung mentioned, that we have in Washington is the rent or temporary housing. And what that specifically looks like looks like is up to 6 months of rental assistance or temporary housing for the target population. Before I get into kind of our design and the goals for implementation, I'm going to go to the next slide, but take a step back in time to kind of talk about foundational community supports and really where it came from and why, in Washington at least, we're aiming to demonstrate the effectiveness of these two new HRSN housing services when combined with foundational community supports. So we launched our program in 2018. It took a full year to negotiate the protocols with CMS for our supportive housing and supported employment services for our target population. So new to the country almost at the time, and really in the space of the support services that help remove barriers to stable housing and employment, to establish independent housing, competitive employment for our target population. We were never in the field of paying for rent, housing, wages, or anything like that. It's really just the support service that helps someone over the long term. So time unlimited support services to help navigate those barriers. So fast forward to now, we're in the space of being able to also cover for certain individuals who are eligible, things like the first and last month's rent, and so on and so forth, ongoing rent for up to 6 months. Next slide, please. Our target population for FCS is structured very similarly to HRSN, and I think for states who are just now getting into the space of using Medicaid waivers to pay for supportive housing services, a lot of them are being approved under HRSN services framework. So if Washington were to start today, that's probably what it would look like, as we would have that benefit approved under HRSN. But since we started back in 2018, we have a really similar structure, but it will look a little different across the country. So unique to our state is that we have these pre-existing services that follow a very similar sort of structure. So as Sagung mentioned, we have to establish medical necessity through qualifying health conditions for our target population. For our FCS support services, an individual needs to be 16 or older and receiving Medicaid. We also serve people who are dually eligible for Medicaid and Medicare, so long as their Medicaid qualifies for the waiver. And we also have those risk factors. So the social risk factors, an example looks like someone who's chronically homeless, who's had a history of frequent or lengthy institutional stays, or frequent or lengthy residential care stays. Currently, the program has around 13,500 people enrolled across both of our benefits. So again, that's supported employment and supportive housing. Those services are based on evidence-based practices that we selected, really to generate measurable outcomes and maintain quality of services, and essentially have a model that we can implement across the state where we maintain service quality, so that people who are receiving services, depending, kind of no matter where they're receiving them, if it's through their outpatient behavioral health provider or maybe their homelessness service provider, they're essentially receiving the similar type of support to navigate that really complex housing system that if you have maybe a serious mental illness and you've been chronically homeless, it can be almost nearly impossible to navigate on your own. And the slides will have, for those of you who want a deeper dive into our eligibility, we have a link to the quick reference guide for eligibility for our program. Next slide, please. And within the first period of our waiver, we've had multiple kind of ongoing evaluations, whether it's through our state at the Department of Social and Health Service research and data analysis. They are internal to the state evaluator of the FCS program, but also for our external evaluator, the independent external evaluator for the waiver at Oregon Health and Sciences University. We've been demonstrating some very strong outcomes through the first period of the waiver, including things like reductions in homelessness, placement in housing that's funded by the Department of Commerce, who's one of our, they're not a partner under the waiver, but one of our partner agencies on a lot of work related to homelessness reduction, as well as reductions in arrest rates, emergency department and hospital utilization, and just really strong outcomes for our target population, again, who's chronically homeless, in and out of institutional settings. If you think about on the employment side, we have a lot of people who are working for the first time in their lives. And so even if it's not, taking a step back from more of the research-based statistically significant outcomes, just thinking of the individual outcomes and the impact on an individual's life who's maybe never worked or who has never had, as an adult, a stable place to live. So pretty significant work that we've done in Washington around these services. And we still have these housing barriers, including lack of availability of affordable housing, as well as lack of access to rental assistance programs. And I noted for FCS target population, but really what I think the work under HRSN is highlighting across the country is there's a lack of available access to rental assistance programs for individuals who qualify for support services based on their health-based needs. So the traditional housing system prioritizes things like chronically homeless, but doesn't necessarily prioritize someone who has a chronic health condition or a behavioral health treatment need, where they might be eligible for waiver-funded services, but not necessarily eligible for long-term rental assistance. Next slide, please. And so the housing infrastructure that we've been developing in Washington for the housing transition navigation services, we really modeled this service in our protocol after our state-funded Foundational Community Supports Transition Assistance Program. Again, that breaks down those financial barriers of how do you establish an apartment? What are the costs associated with security deposits, application fees? Maybe if someone has rental arrearages that need covering, those types of supports, we've been able to start pairing with our support service and use the waiver renewal as an opportunity to seek Medicaid funds to really expand that program. And so that's essentially what that, and I have a link again for more information on that service, but really what we're aiming to do with that housing transition navigation service. It's more of an ongoing support paired with our supportive housing service to navigate the services side and the kind of those one-time cost sides of getting housing. We're leveraging our existing provider network. We have over 220 contracted providers across the state, over, I think, 540 sites across the state providing the service. And we're really leveraging their expertise in the housing world to help with housing search, pay for deposits, pay for application fees. We can reimburse them for those costs. And they can also help individuals establish, again, through purchasing something like a couch or pots and pans or things like that, those basic home goods that really help establish someone in housing. And the rental assistance is really, and we're kind of implementing this in phases. So starting with the housing transition navigation work, since we have that infrastructure existing already, but the new rental assistance benefit is going to shift a bit of the landscape of how we are bringing these services into Washington. I've kind of started having created this mantra that I'm using around the rental assistance, that if we want Medicaid to start paying for things like housing, we really need the money that comes from Medicaid to look like money that pays for housing. So a little bit different than what we've been doing with our, Medicaid sort of fee-for-service type of support service that you bill through Medicaid. We're really aiming to shift how we're paying for this temporary rent assistance by having it look like that, housing money. So working with our partners at the Department of Commerce, we have the Apple Health and Homes Initiative. It's a state-funded long-term rental assistance program that targets the same population as FCS, and working with public housing authorities who are in the business of paying rent. So how can we really pair this short-term Medicaid-funded rent assistance? Up to 6 months is not a very long time, especially when your standard lease is 12 months. But so we really need to work on creating those relationships and partnerships to help transition people from that 6 months of Medicaid-funded service to that longer-term support of ongoing rental assistance. And so really, working to aiming to create that long-term sort of sustainability plan on how we envision this working in Washington. And I think that might be my last slide.
You have one more, but we have
Oh,
about
do I
one more
have one
minute
more?
if you want to add a couple more comments on these last remaining slides.
Oh, no, I think Sagun, this might be back to you.
Sounds good. Thank you so much. We do have just a couple more slides to share. So for this specific slide, this is an implementation approach to share with the group today. Taking into consideration the capacity for implementation as a factor, the state will be implementing the HRSN services in a phased approach. Matt did mention that in the previous slide. So phase one will be the implementation of 4 health-related social needs services. We have the case management, outreach, and navigation, which is the community hubs and the native hub. We have the short-term post-hospitalization housing, known as the medical respite, along with the 2 housing services as well, the housing transition navigation services and the rent temporary housing. In terms of the native hub and the community hubs, so community hubs have launched July 1st, 2024, and the 2 housing HRSN services will be launch date as fall of this year, with medical respite tentatively scheduled for next year, summer of 2025. In terms of all phases for at a later approach, this is something that the state is, are starting to kind of plan and consider not only capacity as an implementation factor, but also budget as an implementation factor. So these are just an overview of that implementation approach. Next slide, please.
So then we'll have to go to the next speaker here in a moment. Do you want to
Oh,
add one
sure.
more comment on this slide? Thank you.
For sure, yeah. I think we'll just go to the next slide. Since we will talk about community hubs, one more. Thank you. And this is just the CMS deliverables. So as mentioned before, we have deliverables for CMS. We have the infrastructure protocol that was submitted and approved. As of right now, the HRSN services protocol is pending CMS review. And then the HRSN services implementation plan was submitted. And as of right now, it will be reviewed by CMS. Thank you so much.
Thank you both so much. Really appreciate it. We'll now bring Tavish Donahue forward to talk more about Healthier Here's community hub model and how they are working at Healthier Here to implement some of the information we just heard about.
Okay, wonderful. Yeah. Thanks so much, Emily, and our presenters from HCA. And yeah, Emily, I believe I had a slide before this.
This one.
Okay, I'll make the best of it. So hi, everybody. I'm Tavish Donahue. I'm the Community Hub Director of Program Operations at Healthier Here. Healthier Here is the accountable community of health, or hub, for Seattle and kind of the surrounding regions serving King County. So first, I want to talk a little bit about what the Healthier Here Community Hub does. So a community hub is a community-centered entity that organizes and supports a network of organizations that provide community-based care coordination services. And the hub, we're really the backbone organization for our broader network. And we're able to centralize operational functions, infrastructure, support our contracted network by, centralizing payment operations, managing and assigning referrals or intakes of new clients, maintaining service delivery compliance, technology infrastructure, IT, data collection and reporting, training and TA, and quality improvement support. So for Healthier Here, operating in King County, we're doing that matchmaking, matching individuals and families who come to the hub with someone within our network, and our network providers all hire community health workers who help those clients find resources, navigate systems, and champion their needs. And as the hub for King County, we are centralizing referrals across the county, bringing together a number of different organizations, largely CBOs, but also behavioral health, healthcare organizations. And as I mentioned, as the hub, Healthier Here is really that backbone entity, providing that centralized infrastructure and support so that our partners and their community-based workers can really focus on what they do best in delivering that care to their clients. Next slide. Okay, so this graphic kind of shows the different partner types within our network. And our network is called the Community Care Network. And you see Healthier Here on the side as that kind of gear, that backbone entity supporting the work of partners within our network. And at the bottom, our Connect to technology. I'll be sharing a little bit more about that in a few slides, but that Connect to technology, that's our client management system and community information exchange, really allowing that flow of data information to really bring the network together. And you can see the different types of partners within the network, case management partners, exchange partners who are plugged into our technology, referral partners, and that referral partners includes both inbound referrals and outbound referrals who our community health workers are connecting folks to. Another category are the HRSN benefit partners. So that connects to, what our colleagues from Healthcare Authority shared as some of those new HRSN benefits get rolled out. And we also have emerging partners who, want to contract to be a provider, but maybe need a little bit of capacity building support first. And then learning sharing partners who are kind of a broader set of organizations who are interested in community-based care coordination in King County and want to stay connected to what we're doing as a network. Next slide. So this slide, and I believe you'll all get it over email along with the recording. This just provides a little bit more detail about what those different partner types within our community care network are. And I really want to highlight, so the hub case management partners, so these are organizations, largely CBOs, who are contracted to provide care coordination services to the clients that are referred to them through the hub, and they work in accordance with the hub workflow and documentation standards. And another partner type I want to highlight are those hub referral partners. So these are organizations, hopefully in the future, a lot of healthcare organizations, behavioral health, who may identify clients who have health-related social needs, and rather than kind of taking that on yourselves, those organizations would be able to refer those clients, patients into the hub for that health-related social needs, social services, care coordination, and system navigation. And then referral partners also include kind of outbound referral partners. So the different social service providers that our hubs, community health workers are referring out to get clients connected to, housing, nutrition, transportation. As we're waiting for the, broader health-related social needs benefits through the waiver to roll out. Next slide. Okay, and why don't you, click 3 times. To get this all on the perfect. Okay, so this infographic shows how our community hub works. And I'm going to walk you all through it from left to right. So you can see here on the left, so clients are referred in to the Healthier Here Community Hub for an intake. And those referrals happen, we're getting a lot of them through 211. CBOs are identifying, folks in their communities who could benefit from the services of the hub and referring them in. And we also get referrals from healthcare providers or social service agencies. And clients are also more than welcome to self-refer in, and they can do that online or over the phone. And then once they're referred in, you see the circle around Healthier Here. So clients are screened by my staff at the hub, and then based on kind of demographic factors, what their initial needs are on the intake form, we match them with one of our contracted case management partners. Based on, again, needs, background, culture, language match. So that, our clients are working with someone who really gets them, understands them. And oftentimes speaks their language. So then after the hub makes that assignment of a client to one of our case management partners, that client is now with their assigned community health worker. These circles in the light green, the teal, and that their CHW then assesses the client's needs, determines what benefits they may be eligible for to help meet those needs, works with the client to set goals, and then connects them to health-related social needs providers by making those outbound referrals, and then continues to work with that client, follows up to assure their needs are met. And if they have other goals, other things they want to work on, that CHW continues that relationship with that client to get them connected to other needs. And then you'll see here on the right, there's kind of 3 buckets of services we're able to connect folks to. So there are new benefits that could include, helping someone get enrolled in SNAP, TANF, WIC. That new benefits category will also cover the HRSN benefits through the waiver that'll be rolled out over the next few years. In the middle, connecting clients to social services. For example, this may be, the Orca Lyft program for discounted transportation, or, a food bank, food pantry to help meet some of their health-related social needs. And then finally, at the bottom, our CHWs can also connect people to healthcare providers. Let's say someone's new to Medicaid and they want to establish care with a primary care provider or get a referral to behavioral health. Our CHWs can do those types of referrals as well. Next slide. Yeah, this slide shares a little bit about who is eligible for services. And service eligibility for our community hub, it's pretty broad. So essentially, it can be anyone who's currently residing in King County, even if they don't have a fixed address, if they're unhoused. And then they need to be experiencing health-related social needs barriers. And some of the ones we're, focusing on are, food insecurity, housing, financial insecurity. And then or, they would benefit from navigation assistance, such as help applying for benefits or referrals to programs. And yeah, currently our community hub clients don't need to be enrolled in Medicaid to receive case management services, because we have some blended funding sources. But one of the things our CHWs are trained to do is, determine, does someone have insurance? If they don't, are they eligible for Medicaid? And then helping them get enrolled so they can become, a Medicaid beneficiary and, be eligible for some additional benefits that way. Next slide. And now I just want to talk about, what really makes the hub hum, what's the magic behind this model. And that is the fact that we use we rely on the community-based workforce. So the community-based workforce, they are trusted messengers who are knowledgeable, well-trained in how to navigate systems. Yeah, find resources and break down silos to ensure that people get the care and services they need. They've walked in the shoes of the clients they're serving, so they're really well positioned to be their navigator, be their coach, help them access the services that can help them thrive, and address some of their health related social needs barriers. And the way they do this is by leveraging trusted relationships with their clients, so that they can regularly identify additional barriers someone may face and provide support to help overcome those barriers. Next slide.
Tavish, we have about a minute left, just so you know.
Okay. Yeah, I just have a few more. So this is our community hub workflow. So when a client is assigned to the hub, this is kind of what they experience. And you see it starts with, outreach introduction, providing consent for services, moves into, doing an HRSN assessment, goal setting. And then there is a cycle that can repeat of finding resources, making referrals, checking progress, and determining if a client is ready for discharge. And that cycle can go on as long as the client needs. And then finally, they move over to discharge when they're ready to, end the program. And they're welcome to come back at any time. Next slide. And I'm not going to read through this slide because I know we're short on time, but you'll have it over email. So the client management system we use is called a Connect2 Coordinator. It's a system set up by a vendor called Ready Computing. And this system, what's really cool about it is it was co-designed with community, a lot of input from healthcare social services providers in our region. And it includes the ability to do closed loop referrals. And that can be done automatically or manually. And automatically is as more providers get integrated with our community information exchange component of this technology. Next slide. And what's next for the Healthier Here Community Hub? So we are building up our network to include more referral partners, including health system partners who may be interested in sending us referrals. And we're also looking ahead to adding those health-related social needs benefits for Medicaid members as those new benefits through the waiver roll out over the next few years. So we're very excited because right now that's kind of the missing piece in our case management model. since right now we're so reliant on just resources being available in the community. And yeah, that is it for me, and I'll pass it over to Michelle.
Thanks, Tavish. Hello, everyone. My name is Michelle Ahmed, and I'm the Director of Health Connect Hub at Swatch. Next slide. Swatch is the ACH that supports Clark, Skamania, and Klickitat counties. And I have the benefit of following Tavish, who did a lot of the explanation of what a community hub is in general. So I won't be focusing so much on that, but the history and implementation of the hub in Southwest Washington. We actually started our hub in, it says 2017, I'm sorry, it's 2019. It was started as a Pathways community hub model, which was part of the MTP 1.0. Pathways is just a evidence-based way of supporting care coordination in the community hub. And we actually started our eligibility with adults on Medicaid over with chronic conditions. We expanded in 2020 with the pandemic. We added a program that supported quarantine and isolation called Care Connect, which is a program that's part of the Department of Health in their COVID response. And we added that in, and we're still using the Pathways model, which it really focuses on outcomes to this day. Next slide. Once the pandemic hit, we readdressed our eligibility criteria for the hub and opened that eligibility up to everybody in the community in our region. We just didn't know how the pandemic was going to affect everything. And that really led us down to what we call what's often referred to as the no wrong door approach, which allows any community member to be referred however they find us, through one of our partners, through a phone number, through calling the call center at the state. So any way they find us, we try to find support for them. And through that time, we expanded from 4 partners and 8 CHWs to 12 partners, with it averages around 44 CHWs. A lot of these partners have existing programs. They have programs like FCS and PATH and HARP and health homes. And our partners really like partnering with a community hub with no high eligibility criteria or like a requirement of service lengths or anything, because that allows them to support all the community members that they serve and find a program that fits them. Next slide. So this is just a slide that kind of explains in the same way about what the value of a hub network is, more through a community member perspective. But I do want to touch on something that Tavish mentioned, and that is really working with the community-based workforce. Community-based workforce which encompasses like community health workers, peers, recovery navigators, recovery coaches, social workers, everybody who's working out in the community, notoriously under-resourced and high turnover. And through our work, we're really trying to support them with training and development, not just for our contracted partners, but for any community-based worker and any partner. Having a hub also helps to stabilize funding and sustain funding for these kinds of programs. And we use a shared data platform just like Healthier Here, which really allows for the capture and reporting of data and outcomes in the region. I wanted to touch on really quickly a particular partnership that we have with a health system, because I know that there are a lot of healthcare providers on this call. We partner with Peace Health as a referral partner. So Peace Health Southwest Hospital in Vancouver, Washington, partners with us for a program that's called Patch. And that is a program that supports care transitions for houseless individuals. There are community-based workers that come into the hospital while the individual is still hospitalized, and starts supporting them before they leave the hospital. This is a population that is notoriously hard to find once they're out of the hospital. The other thing we're partnering with Peace Health on is Peace Health has created a community health hub, a physical space that is part of their new emergency department. And they are working with us to support the capture of data and tracking for the partners using that space as far as referrals and outcomes go. Next slide. I wanted to touch on alignment. So Swatch has had the community care hub that's been operating since 2019, providing case management services, just as it stated in MTP 2.0. But one of the things that is changing for us is alignment. We've been working with the Department of Health and the other ACHs to form alignment between services and standards, so that they're in place across the state. That is a little different from us. We started kind of on our own, and we want to make sure that we are aligned in things like care coordination standards, contracting and network management, workforce development, screening and assessment, data sharing, funding, all of that stuff. Because we know that while we are in our own regions, many of our partners cross regions. We want to provide similar services for the entire state, and this is something that's going to be new to us. All right, I think that was my last slide.
Thank you so much. We will now transition to a Q&A with our speakers. We had quite a few questions come in, so please keep adding them and we'll try our best to ask them to our speakers. 1 second. Sorry, one moment with my computer. But while I'm working on something, Michelle, there was a question that came in that maybe you and Tavish could help answer, which is really talking about going on this idea of the alignment. Is our hubs working together when they encounter a client who lives and accesses services across multiple counties or across multiple of your ACH areas? And if so, can you kind of elaborate on what that might look like?
You want me to take this, Tavish?
Yeah, that would be great.
Okay. Yeah, it's not uncommon for us to either receive referrals from referral partners who cross areas, or to have participants move. And when it is available, we actually transfer the chart itself to any other ACH using the same system. When not, we support the participant and the community health worker that's currently supporting them to find a program that is similar. Oftentimes it is an ACH with a hub, but it could be, I mean, we support them in Portland, for example. We're in the Portland metro area. So we both work to find services in our region and outside of our region when appropriate. And it isn't uncommon for us to find, for example, Peace Health St. John's and in Choice's region of Cowlitz County might refer to us, and then we would work with Choice, who has a community hub, to transfer that referral to them.
We have a question for the HCA that came in. Let me grab it. On your slides from earlier, there was a portion that was talking about some actions that are dependent on financing for your later phases. Could you elaborate and clarify what this means? And then does that mean they may not be implemented in the future?
Sure. I can go ahead and take a first pass on answering this question. So the state is right now currently in the planning phase for the phase 2 HRSN services, and as the slide kind of showed, are the rest of the other HRSN services. And we're both, we're considering capacity and financing as some of the factors for implementation. So waiver dollars are capped by the federal government, and we are considering the costs for implementing each of the phase 2 services when we're determining on implementation. I'll also go ahead, if possible, would also kind of invite my other HCA folks, specifically Michael Arnes, who is the Deputy Policy Director, if there's anything else that he would like to add to that. Thank you. Thank you.
I think I'm on now, Sagung. Sagung, thank you. No, that was just terrific. We do have each of the HRSN services budgeted under the waiver, but as Sagung was mentioning, they are capped as well. And so as we implement some of those phase 2 services, we don't know what the true expenditures are going to be on them. And we may want to make some changes as we go forward. And provide more of some of the services than we anticipated, simply because the need is shown to be so great. But right now, no, we have plans to, we have budgeted for all the services, and we have plans to move on them. So thanks.
My next question is for all of our speakers. I'm curious, how is your organization balance prioritizing certain health-related social needs? For example, the HCA was showing housing, without neglecting others. What factors influence your decision on where to start?
So I can take that off for the hub perspective. So yeah, Healthier Here, we've also had our hub for a couple years. We're not quite as established as Swatch. We started in 2022. So we've had a couple of years of initial data on, what were the top needs coming out of the clients assessments under the Care Connect program. And we just saw a consistent pattern that it was housing, it was utility assistance, it was nutrition supports. So for us, that was really a data-driven decision, based on what we're seeing about the client's needs.
I can answer for Swatch. There is a holistic assessment that happens at the beginning of enrollment that touches on all of them. But as Tavish said, there are always certain needs that rise to the top, especially housing. So when I think about neglecting, what we really need is time with the person, because we're always going to have to address those most acute needs first. And given time, we've identified what the risks are, but if it's something, if they come in needing housing, that's what they want to address. But we also see that they have dental pain. It might take some time before that person, is in a place where they are ready to go to the dentist because other needs are met.
Sagun or Matt, would you like to add anything to that question?
And from the perspective of the work that we're doing under foundational community supports, I think a lot of the work around the short-term kind of housing subsidy space is infrastructure that we've been working on developing over the last several years. And so maybe low-hanging fruit's the wrong term, but just leveraging kind of the existing framework that we've built around foundational community supports with, again, our provider network and the opportunity to start addressing the financial barriers to finding and obtaining stable housing is really just the opportunity that we were exploring in the first place when we applied for the waiver renewal, before we really knew how it would look under this new HRSN services framework. So that's, from our perspective, really the continuing to address the barriers that we've known that have existed since prior to the renewal of our waiver.
So within the BRE and the foundation space, we do a lot of work across the healthcare ecosystem and with a lot of different audiences. So with health delivery systems, health plans, employer organizations that purchase health insurances for their employees. I'm curious, how can these different audiences effectively engage with either the community hub model or with these updates to the 1115 waiver to enhance their impact and support client needs?
Yeah, I can start that off with a pretty general answer. Yeah, I think it's important that we don't create silos and that we're linking arms with other providers across the spectrum. Yeah, because it's not just one provider who's going to have the most impact on an individual. It's about us collaborating, being aligned.
In an ad, we are continuing to leverage a lot of the existing infrastructure in Washington, and one of the areas that I highlighted around engaging the public housing authorities and other programs in the state that have longer term rental assistance resources, really looking to different examples from across the country. We're participating in the Health and Housing Services Accelerator, with HUD and HHS, and looking at different ways to bring in community members, different organizations across the state, again, public housing authorities being a good example, working with the different players in the homelessness relief system, but also acknowledging kind of the work that we've done to establish this new to Medicaid sort of billing provider type under our waiver, looking at community-based organizations, nonprofits, faith-based organizations, and other service providers that are not historically billing Medicaid for support services, in ways that we can bring in different players into the field of paying for housing support.
And Michelle, earlier you were talking about a relationship that Swatch has made with a health delivery system down in Vancouver area. Kind of going with this idea, there's a question in the chat, how are you reaching out to those healthcare providers so they know about your services and how to get referrals to you?
We do have, a communications department, but we actually at this time have to be pretty, I wouldn't say selective, but careful about who, those kinds of relationships. Anybody can and does make referrals into the hub, usually at an individual employee level. But we do want to make sure that we have capacity to partner with our health systems partners in the way that we're doing with, as an example, with Peace Health. And we really think of that as like a test of change to see how that works. As we kind of iron all of that out and how those partnerships work, we'll continue to extend probably first to the hospital systems and the EDs, because that's been a big focus on cost reduction for the emergency department utilization. And then to other partners, we do have our one and only FQHC, for example, is a partner with us already. They provide services. So I know that's not probably the answer you wanted, but there is a little bit of calibrating there with partnerships just to make sure that our network can support everybody.
Thank you. And Tavish, I saw that you added in the chat that at Healthier Here, you're just starting to do some of that outreach and awareness campaign.
Yeah.
There's one more question we have time for is, are all of the community hubs using the same electronic referral programs? They're thinking about how this may integrate into the EMR systems for the health delivery systems.
Yeah, I can kick that one off. I know Michelle will have things to add as well. Right now, we are not all using the same, electronic client management system. There is consistency with referrals coming in through 211 crisis connections. They're doing individual APIs with the various client management systems used by the hub. And Healthier Here with our Connect 2 system through Ready Computing does have the ability for systems to integrate with one another to be able to share information. And one of the other ACHs is going to be integrating starting this fall. And we're having some conversations about kind of the feasibility of that for the others. But yeah, it's purely voluntary.
Thank you for that clarification. And I actually realized I have one more last question for all of our speakers. I'm just kind of curious, as we're developing these community hubs, rolling out the new 1115 waiver updates, what are you most excited about? If you can quickly state one thing that you're really excited about in this upcoming waiver and rollout. And Matt, maybe we can start with you.
Yeah, no, one of the things that we're just thrilled about is just being able to have these conversations about what does it look like for Medicaid to be paying for housing, any duration of time, even though maybe 6 months isn't long enough, just to think of where we've come in the past 6 years of not even being able to use the word housing in our protocols. We called it community support services, to now being able to specifically say paying for rent and temporary housing is just really exciting. It's a bit daunting. It's kind of a whole new world, but just really excited to start chipping away at it.
Sagung, do you want to go?
Sure. I'm really excited that not only are the programs that are from MTP 1.0 are continuing into MTP 2.0, but these new programs that have been approved for, it would be really exciting to see all of these new programs actually implemented and operationalizing. So not only the health-related social needs, but also the justice involved program, the services for that, the community hub. So all of the MTP 2.0 new programs to actually be kind of up and launch and running. Thanks.
Tavish, do you want to go?
Sure. So one of the things I'm most excited about is that kind of for the case management services, it's fairly yet low barrier. So I'm really excited that it's an opportunity for folks who are maybe just starting to fall on hard times to access some of those, navigation support services that until now have been more for, specialized populations, with a lot of needs, high PRISM scores.
And Michelle, we'll wrap up with you.
I'm excited about the opportunity that exists for the social needs care and the social care providers to participate in the healthcare system as a new form of funding for them. Because they've been doing the work for a long time.
Yeah, absolutely.
Yeah.
Well, we want to thank our speakers for presenting today and for answering our questions. We're going to transition where we recognize there's so much great work going on in the state in this topic. There's so many players and people who are spending so much dedicated time on these topics to help support our patients and our collective patients of our Washingtonians, and even those out of the state supporting some too. And so we wanted to provide an opportunity where we can connect with peers and hear about that further detail and work. So you will, in just now, I think in a second, you will see an opportunity to join a breakout room. We do have staff from the foundation and the BRE who will be facilitating discussion where you can connect with peers. And then after that conversation, we'll come back and wrap up the event and let you know about some more events coming up. Thank you so much. And seeing if there's any further information that would be helpful for us to know so we can plan more events and topics that are relevant for all of your work. I'm going to show you in a second how to claim our CE credits. They will be emailed out to you. You need to complete that survey first, and more directions will also be emailed. We also just wanted to share too, we have quite a few upcoming events. They are similar to this one, but just on different topics. Where next week we're looking at pre-diabetes care pathways to connect patients with community support. We will be highlighting a YMCA on that one, doing diabetes prevention program. We're going to be talking more about the sustainability of health equity from the perspectives of health delivery systems, health plans, CMS, on September 11th. And then we'll be looking more at nurturing bonds and perinatal behavioral health and supporting those dyads in care in September as well. To claim CME, you will need to complete that post survey that we have put a link in the chat and will be emailed. Once you complete and submit that survey, this screen will pop up. You will see it says, if you'd like to claim the CME credit, please submit your information here. You click that and you will be taken to a CME claim form. In that form, just please provide your information, and then I will work to follow up with you in the upcoming weeks to provide you with that certificate. But we want to thank everybody for attending today and our speakers. It's been so lovely to have all of you join us and engage with us. It's been such a wonderful group, and your engagement has been fantastic. We are grateful for you to be here today, and we hope to see you at our upcoming events. Thank you so much, everyone.